Okay, now we are live. Good evening, Dr. Lee Walker.
Good evening.
Hope you are doing great. Let me first introduce you. Today, my guest is Dr. Lee Walker. He is the founder of the Lee Walker Facial Aesthetic Academy. He is also the director and clinical lead at the multi-award-winning BCity clinics. He is also the founder and lead speaker for the Northern Aesthetic Practitioner Group. He's also an expert advisory panel member for Safe Face and an expert speaker and demonstrator for Teoxane U.K. Not to mention that he's a faculty lecturer at the Royal College of Surgeons, and you have a lot of great achievement. I can keep doing this for a long time. First, thank you for accepting to join in this webinar. It is such a great pleasure. And today we are going to talk about the dermal fillers. So we always emphasize on how much to be fully aware of the anatomy before we do the injection process, in order to achieve a good results and a safe results. And regardless of how many times we try to avoid doing a complication, yet complications might happen. Do you think that most complications occur due to the technique of the delivery of the product and the practitioner skills, or there are some materials that have a natural tendency of causing complications regardless of the practitioner who is using it?
That's a really good question. It's a very difficult one to quantify, because I think it's a combination of all of those things. In terms of technique, we know that there is a multitude of techniques, and there's not many evidence-based. So you could say that the practitioner is being led by the eminence, or a fad, or a phase. And we're seeing that now with, we spoke about it briefly about different sorts of lip techniques, but it goes the same for the temple, the forehead, the nose, and every other area. There is some techniques which are more dangerous than others. Regarding the filler, I always say to all of my students is that you always have to consider and justify anything that you use. So I don't use any semi-permanent or non-reversible fillers, which I can't dissolve with hyaluronidase, because I feel that's a huge problem, and that would be my problem. Yes, there is many people who say you can use sodium thiosulfate to get rid of radius. That's not the case. That was used for nodules with minimal sort of success and very low number of cases. So we can't rely on those things. So it is a combination of what I feel would be technique and product selection. Because remember, the tip of the needle is the opening, the bevel is around about 1.2 millimeters, and that's where the damage is done.
Mm-hmm. So it's like it's a mixture of both and cause the complications. Okay, so speaking about complications, there are early complications, there are late complications. Some things that may occur at onset immediately after, while you're doing the injection. Some things may occur after a week or after 1 month. So speaking about allergy, is it possible, for allergy, is it possible to be delayed or an immediate? That is the first thing. And does allergy occur due to the hyaluronic acid product itself, or due to lidocaine that is present with it? Or it may be both?
Again, it could be a combination of these things. In almost 20 years of injecting, I've never seen a true type 1 hypersensitivity and anaphylaxis to dermal fillers. I've seen traumatic angioedema where the lip is just swollen pretty instantly. I think we have to look at it a little bit sort of deeper and look at the immunology of the patient as well as the product that you're using, because again, it's a combination of not just the practitioner and the product. This time there's a patient involvement, so medical history is incredibly important. We're seeing more and more delayed onsets now, because more and more people are reporting them for one, and we're starting to understand the link between low molecular weight, high molecular weight, and the low molecular weight being pro-inflammatory. So as the product's breaking down, then this is when we're starting to see these delayed hypersensitivity reactions now, and sometimes they're coupled with a flu-like illness which precedes a couple of weeks. Now we're seeing those anything from a 1 month all the way up to a couple of years, really. and that's what we've seen with all of the complications. There are, as you say, there are immediate, there are early, so within the first 5 days, and then there's late after that. And as I say, I've not seen anything in terms, even in the terms of lidocaine allergy. I used to work at the dental hospital here in Liverpool, and we used to have a local anaesthetic challenge clinic where we used to do tests for lidocaine allergy. I never come across one. It was normally the adrenaline inside causing somebody to feel very anxious. They were giving it intravascular. So again, it's incredibly rare. Not to say that it could never happen, but in my experience, I've never seen a type 1 reaction to dermal fillers.
What are the causes of causing lumps and bumps, especially in the lips? Are it due to placing a filler with a high viscosity, or placing it too deep and due to muscular activity occurs? What do you think that the real cause of causing lumps and bumps in the lips?
Again, it could be exactly what we've been saying. It could be the practitioner using highly cohesive high G prime fillers in the lip. We see that the product doesn't match the dynamics. So you have intramuscular placement, and the muscle will move the filler into almost a bolus. Even if you do linear threads, it will move it into a bolus. Then you've got the filler which is too cohesive, so the particles are attracted and they don't spread, so they just stay together. So highly cohesive or too cohesive fillers in there are problematic. The other things, again, is just placement of bolus instead of linear threads.
Did you know well that a lot of people are doing those techniques nowadays, especially with the Russian lip technique and the 50-50 lips? They tend to place bolus across the tubercles.
Yeah, and again, you have to be very careful with your product choice. I use a product which is, naming no brands, obviously. I use a product which is a dynamic filler, so it's got a lot of strength and stretch, and it's perfectly adapted for the perioral and any area of the face which is dynamic. So for me, product choice is incredibly important. I think placing the filler behind the muscle is a problem in two concerns. The first concern is in almost 80% of cases, the artery is in that deeper position. And secondly, because of the shape of the muscle, then the filler can redistribute behind the muscle and almost end up as two almost hanging sort of areas just underneath the lip into the mucosa. So I don't place any filler into the submucosal area. I always place it in the subcutaneous plane into the fat in front of the muscle. And how I do that, I use a 4mm needle. So I don't use a long needle. And hopefully the technique is about to be published within the journal. So you'll have to wait a little bit longer to look at the rationale behind the technique, behind the 4mm technique, because it's a lower risk. One of the important things for your viewers, Noury, this evening is that there's no safe areas to the face. There's just high risk and low risk. There's always
I saw this amazing picture that you posted on the Instagram, where it was like two pictures beside each other. One picture showing the risk areas, then you market the whole face at the red area. There's no, because you know there is always an anatomical variations, and you know, speaking about aspiration, the primed and unprimed needle, this whole dilemma. Some people believe that when you touch the bone, you are on the subperosal level, you can never be an artery. But still, in your clinical practice, you may be touching a bone and you do an aspiration and you find the blood. So what is your own opinion about this? Should we always stick to the cannula, or it depends on the clinician? Or what is your own protocol for providing a safe injection and avoiding to get in an artery?
I think one of the things that we have to go back and say to the viewers watching is that there's been 6 cases of blindness by using a cannula. So a cannula is not safe. It's just lower risk, and it's all about mitigation of risk, really. In terms of aspiration, it's a very controversial subject, and the literature is incredibly weak from a scientific point of view, because we don't really do in vivo studies for aspiration. The last paper which has been done is 213 aspirations from a single practitioner, and it's very controversial. It's very contradictory in terms of the deep injection into the deep piriform space give the most positive aspirates. So again, it tells you, like you were saying, is that even if you're on the periosteum, there is a risk. Now, my own thoughts about it, I think it's going to be very difficult, because most internal diameters of facial vessels are 1 millimeter or less. So it's going to be very difficult to hold that 1.2 millimeters. What I think, and I'd like somebody to prove it, there's someone a little bit more intelligent than me, is that I think that we go through the vessel and that we have an extravascular bleed, and then we aspirate the extravascular bleed, because if it's vein, it's very likely to collapse under the negative pressure. And to get it into the artery and to draw that amount of blood up, again, for me, I'm not convinced by aspiration. The other consideration we need to consider is that the syringes that we use were never designed to aspirate with. So we don't have the geometry to allow. This is why we have so many false negatives within it now. And I think aspiration is only 30% accurate. And within the last study by Richard Torbeck, then you have to do it for 30 seconds with 0.5. And again, can we really replicate that within clinical practice? Are we going to do that? Now, if you don't aspirate, then you must do something else. And the signs, most of the signs and symptoms of vascular occlusion or intravascular injection are noted right throughout the literature, and they're pain and blanching. And people always say to me that, oh, the patients don't always feel pain. They do, but they just don't tell you. So it's one of these things where people think, or patients think, that this pain that they're feeling is just a needle. They're not. They don't want to move. They don't want to tell you. So pain and blanching. So what I say to the patient is, when I inject, I say to the patient, the first injection is 7 out of 10. If it goes to 8 or 9, tell me. If you feel it in your nose, your forehead, in your eye, in your chin, somewhere distant, then tell me, because it means that I'm inside your artery and you could go blind. And they go, okay, whilst I'm doing that, then I scan the skin. I scan the skin for any areas of blanching. Now, if I'm injecting the nasolabial fold here, then I could have a blanching in the nose, in the forehead, out into the cheek here. So I look for blanching. So I'm doing two things. First, I'm asking the patient about the pain experience. Is it going up? Secondly, I'm looking for blanching. Third, I inject very, very low, because we know that pressure is the enemy. And we can easily exceed 166 milligrams. And that's the pressure we need to get to the retrograde, to the back of the eye. So we know that. We know we can exceed those forces. So I inject very slowly under very low pressure. The other thing I do is targeted digital pressure. And we all have fingers. So if I'm injecting the nose, then I will push on with my non-dominant hand onto the supratrochlear arteries, or grab the dorsal nasal arteries and really push them before I start to inject. Again, it's just about to reduce the risk. And where I can, I use a cannula. So that's everything I do. If you don't get a positive aspirate, then you must do those other things as well to make yourself so much safer than you do if you just do this snap aspiration. It doesn't mean anything.
What is the size of the needle or the cannula that you prefer to use concerning the gauge?
The gauge is 25 or 22. 27 has been proven statistically to be the same as the 27 gauge needle. So again, 25 or 22 is pretty much your go-to for any work with a cannula.
Mm-hmm. Do you think that some people do poke the skin with their pilot needle, then they enter with the cannula and try to push it vertically down to bone? Do you think that this is a little bit a safer technique if you want to do something deep to the bone without using your needle?
Yeah, you can reach the periosteum with a cannula. And what I always see people doing is I see them going with the pilot needle all the way to the bone first, and then they follow with. You don't need to do that. The pilot needle is for one thing only, and that's to breach the skin. Once you're through the skin, you can just feed it through the tissue layers very, very easily. Going all the way down is really, you're risking a hematoma, significant hematoma. Just going through the skin, you can do this. And a little tip or a trick for you is to just grab the tissue like this and keep it up until you go through. Because here in my fingers, I have the skin, the subcutaneous fat, and the SMAS. If I just go through this, then I'm in the deep fat, and then I hit the bone. It's very, very easy. It's a really easy technique. A little tip for all your sort of all your viewers is to just make a little composite.
You're giving it amazing. Speaking about vascular occlusion, do you think that it occurs due to depositing your filler product inside the vessel, or sometimes the filler may compress the vessel and cause a vascular occlusion?
All of the evidence tells us that the pathophysiology of vascular occlusion has been proven to be that there's filler inside the lumen of a vessel. Now, one of the interesting things that you said, Noury, is about compression. It's very interesting that we don't get compartment syndrome in the face. We have it in the peripheral limbs, but we don't get it in the face. And we've seen huge cellulitis, huge trauma, and we don't see a compression. But we expect to put 0.1 hyaluronic acid here and it to compress those arteries. I speak to my surgical colleagues all the time who talk about ligation, and they still have perfusion once they've ligated. If you think about it, if you fell asleep like this on your supratrochlear artery, and it was for 3 or 4 hours just in this position, you don't wake up with a necrosis.
Yeah.
It doesn't. Now, there's been one study, and it was just a single patient of hyperperfusion with filler, and it could have been for a million reasons. With a Doppler, there was a reduction in blood flow to the area. It wasn't hugely significant. It didn't cause any necrosis. It was just that the blood flow was a little bit slower in the area. Now, that doesn't mean it was compression. It could have mean that there was a slight blockage in the artery. And that was a study by, I think the author was called Nima, and it's a single case study, so the evidence is incredibly weak. In my opinion, we don't get compression because we'd see so many more vascular occlusions, especially when you do barcodes here. You'd be compressing the capillaries into the skin, so pretty much everyone you injected would have a compression. So again, we don't see this. I've not seen it, and certainly my surgical colleagues don't agree with compression of dermal fillers. And again, we hear these throwaway phrases, Noury, like a filler will draw 1,000 times its weight in water. So if you've got 1 mil, then you've got, what's that?
All your patients are going to suffer from compression.
Water in your face. Yeah. So again, we sometimes have to think in common sense. You know, how many times have you seen a large infection in someone's face, a big periorbital cellulitis or trauma, huge swelling, no compression, no vascular occlusion, no necrosis, no livido on the skin, because the head is designed very differently. Remember, this is the brain, the airway, the eyes. We don't want to swell and cut our blood supply off. We're a far more sophisticated species than that.
Okay. So when we do have a vascular occlusion, we always hurry on to use hyaluronidase or Hyalase as we have it here in Egypt. I don't know what is the brand that you have it at UK, but we have Hyalase here, which comes at 1 of 500 units. Given the fact that hyaluronidase doesn't have a mind of its own, it will act on hyaluronic acid, whether you injected it, whether it is a native ground substance in the body. And usually when patients tend to have a complication out of filler injection, either they are going to be like severely psychologically traumatized and they're not going to want to do anything else, or they want to have a new filler. So how can you control using hyaluronidase to resolve their issue and not break the native ground substance of their own? what is your own protocol of reconstitution that you advocate? Because I always hear people saying use as much hyaluronidase as you can to resolve the issue, but I guess this doesn't make any sense.
Well, again, it depends what the issue is. If the simple issue is you've got an over projection into the cheek, and how do you get rid of it? It depends on what brand you use first and foremost. We use Hyalase the same, 1,500 units by a company called Wockhardt. And I know that there's lots of different brands across the world with different potencies. What you'll find, Noury, is that lots of countries have what's called compounded hyaluronidase, and that's mixed by the pharmacy. So they will tell you it's 1,500 units, but it's 1,500 units diluted in 10 ml. So it's so weak. It's not gonna.
Yeah,
it's not
speaking
gonna.
about the Hyalonexia, the recombined.
Again, Hyalonex is 150 units, very incredibly expensive, but its molecular potency is so much higher than hyaluronidase. So the Hyalase we use. So again, it's supposed to be, looking at some figures, around about 100 times more potent. So that's the reason why they don't. They only have it as 150 units. It's a recombinant DNA from Chinese hamster ovaries, and there's no reported cases of anaphylaxis or allergic reaction hypersensitivity with that. So going back to the question, it's the classical trying to have your cake and eat it. It will remove endogenous hyaluronic acid. It's indiscriminate, so it will do that. So if you're using it correctively, then I would suggest you just use a small amount and then try and blend the area out. In a vascular occlusion, it's very different. We know that when we inject hyaluronidase, it only has a half-life of 2 minutes, so it's not around for a long time. And the other thing is it's being diluted by the serum leakage. We have anti-hyaluronidase enzymes attacking it, and it's also being diffused away from the site. So around about 60–70% is inactive, and that's the reason why we say always put a high dose in. Now, going back to the high dose, with Claudio Di Lorenzi's high dose pulsed Hyalase, he used compounded hyaluronidase. So he admits in the paper that he doesn't know whether it was a high concentration or a low concentration. So again, it tells you that there is still work to be done to elucidate the correct dosage, the dilutions, whether we should use adjunctives, because anytime I use hyaluronidase, I use lidocaine without adrenaline with it. It does two things. One, it vasodilates, and the other thing, one of the most important things, it facilitates the rigorous massage. And when I mean rigorous massage, I mean really rigorous, because like I said, there's around about 60–70% inactive hyaluronidase. You're going to need two things. One is biomechanical and the other is biochemical, and you're going to have to break it down with your fingers to allow the hyaluronidase to spread through the filler. We also know now that we have so much more product being used. So volumes have increased, the concentration of hyaluronic acid has increased, the cross-linking technology has got a lot tighter now. So we're finding things, what we used to do in the past many years ago, it wouldn't have an effect on modern day fillers. So that's one of the reasons why we now suggest that you use a high dose.
Mm-hmm. How much lidocaine units do you use it for the volume, concerning the volume, do you use it for the reconstitution of your Hyalase?
Again, there's a bit of contention when it comes to whether or not you reconstitute with the lidocaine or you reconstitute with normal saline. I don't reconstitute with the lidocaine. I use the lidocaine. So say, for example, we have an area of ischemia here. Then I will put the lidocaine all through this area here. Okay, because very easily you could give a block if you wanted it to just, but I don't want it to just give a block. I want to increase the perfusion. Yeah, the perfusion in the area. So I pretty much mirror how I'm going to put the hyaluronidase in, and then I wait for around about 2 minutes. So I'll use between 1 to 2 cc of lidocaine without adrenaline, and then then I can happily put lots and lots of hyaluronidase into the area when the patient's very comfortable. One of the things you find out when you've done enough vascular occlusions is that ischemic or necrotic tissue, when you put hyaluronidase in and you try to massage it, it's so painful. Your patient is not going to allow you to push hard. And that's the reason why you really get to this crusting stage, because you haven't used enough hyaluronidase, and you certainly haven't massaged it. So my biggest tip, or your biggest friend, Noury, would be lidocaine without adrenaline first. Get your patient comfortable, and then you can pour on as much hyaluronidase as you wish. Now, I've had, in my experience I've had 2 personal vascular occlusions myself. I've had hands-on now with 60, so physically treated 60, and had over 200 indirect. So people FaceTime, people sending videos in. So I know what works now, and I know how to sort of manage the situation. And it comes down to 2 things: lidocaine and lots of hyaluronidase. Because the problem is you've got dermal filler within the lumen of the vessel. That's your problem. You've got to get it out.
Mm-hmm. What are the areas that is more risky to cause blindness?
Wow. Everywhere can cause blindness, because it goes back to the pressure. So there's cases of chin causing blindness. If we look at them in terms of the number 1 area for blindness, then it used to be the glabella, now it's the nose. And why has that happened? Because like me, when you go to a conference, they say this is the most dangerous area, don't inject. So everyone says, okay, they do a nose in 15 minutes, it's no problem. So the nose is number 1, glabella is number 2, forehead is number 3, and this will really surprise you, number 4, nasolabial fold. Mm-hmm. Nasolabial fold is the 4th most common area for blindness, and traditionally, how are people trained? They do a nasolabial fold first. So again, with a needle, and again, it's depth of the vessels, which is the most important factor, because like you said a little bit earlier, anatomy is aberrant, anatomy is very variable. Distribution, you couldn't have a facial artery here. It might be out with the facial vein duplex out here. But we know the depth. We know it's subcutaneous here. We know it's most superficial here, so we inject deep. We know it's deep here, so we inject superficial. So we understand the depth of the vessel is the key to being a lower risk injector.
Mm-hmm. Regardless blindness, I guess this is the only situation where you do a retrobulbar injection for your hyaluronidase at the supratrochlear supraorbital artery. Do you also advocate other methods or other injections to prevent this catastrophic sequela?
The evidence on retrobulbar hyalase is not very strong, and actually there's a systematic review just being done, and it says don't attempt it because you can cause problems. The biggest key factor here, Noury, is that you have a time critical event, and if you spend 2 hours trying to do a retrobulbar block in a retrobulbar hyaluronidase and it's not successful, we know that traditionally what we thought is that there is a 97-minute window for hypoxia to the retina. We don't know now if it's between 12 to 15 minutes. So the timeline is a lot shorter than we anticipate. Now, if we just look at the anatomy of a retrobulbar injection here, you're trying to find the central retinal artery. Okay, the central retinal artery's position is medial. So why we give it in the lateral position? I don't know. It doesn't make any sense. And the distance of the central retinal artery outside the octave dura is a few millimeters. So we're injecting in the wrong place in terms of trying to find the central retinal artery. And it's a very small space, because we know from lots of publications now is that hyaluronidase does not pass the blood-brain barrier, and it does not pass the octave dura. So again, should we be doing it? Should there be something else? Supratrochlear, supraorbital would be easy to find. Angular artery would be easy to find. You can inject it under pressure. My advice would be to do simple things like globe massage. Again, it shows that you have a 16% increase in oxygen perfusion into the back of the eye, rebreathing into a bag to increase carbon dioxide for vasodilation. These things you can do without any risk whilst you're on your way to the emergency room, because we need to start thinking now, how many people are trained to give a retrobulbar? How many people would be confident? How many people would stick the needle into the back of somebody's globe? You know, the orbital cone is 42 millimeters long, so you're going to have to use a 50 millimeter cannula to get to the back. And the retrobulbar space only has room for 5 cc's before you have problems. Again, so it's for me, it's all about getting your patient to the best chance of salvage. And I don't feel, unless you're an ophthalmologist or an oculoplastics, that the best chance is with you, the best chance is in hospital.
You will have to contact Dr. Sabrina Shahid about this issue so she can solve it. So
Yeah.
we have a question. We have a question from Annie here. She is asking about, can you please, Dr. Lee Walker, speak to us about the safety of injection into the Piriform aperture? Thank you. Okay, a lot of people do inject at this area, especially when they want to give a little prominency here. And also at the myomodulation concept, they do tend to inject filler deep at this area to give a non-surgical lip lift. How can we do a safe injection at this area?
Okay, so it's one of those areas where it's a very frightening area to inject in, because you're thinking of the facial artery. That's if the facial artery is there. Okay, that's what you always have to remember. It mightn't be here, it could be out here. You might have a hyperplastic one which stops here. Again, if you're injecting, I don't like this angle where we go in like this, because you've got to really think about, what are you trying to achieve? You're trying to achieve maxillary projection, deep fat from this risto space or the deep piriform space to push the tissue forward. How do you find the bone? Well, it's 90 degrees, so a straight injection, bump right down. Angling in like this, you're risking hitting vessels inside the nose. And we've seen a case of sphenopalatine injection here, palatal necrosis, gum necrosis, and the septum that starts to necrose by these injections that you see injectors going at a very strange angle. The shortest point from A to B is in a straight line. So I always inject deep, touch the periosteum, and inject incredibly slowly. Now, your patients may feel pain here, and there's a reason for this. Because this is a very fixed and tight area, and we're worried about the facial artery, what most practitioners do is that they push onto the bone. And you know that the periosteum is very, very highly innervated. It's very painful. So they're pushing the needle onto so that the patient's like this, and they think they're going to have an occlusion because they think they're intravascular. Again, just tell them it's going to feel a little bit tender here, and just inject very, very slow at a 90 degree, just not like this, just bump straight, perpendicular to the skin, straight down. Again, small amounts, 0.1, 0.2, very, very slow. Keep looking at the tip of the nose when you're injecting. Keep looking around the cheek area here, and just ask the patient on a scale of 1 to 10 how painful, and they'll say 3, 1, I can't really feel it. And that's because the lidocaine's beginning to work as you're working very, very slowly. So slow, low pressure injections, touch the periosteum and then slightly release, and then watch for those signs. Okay, but a 90 degree angle.
Yeah, can we do the technique that you were talking about a little bit earlier, when by poking the skin of the needle and going with the cannula, or we doesn't have to do this?
Again, the same. You can do that. You can lift up the skin, pop through it, just pop through the skin, and then again just touch with the cannula here. Again, it's a great, and as you say, it's a very, very valid technique. A lot of people are afraid of cannulas. They think they're very technically difficult. It's not. It's just as easy as a needle. Yeah.
Mm-hmm. Let's see. So speaking about granuloma, it's a non-allergic chronic inflammatory reaction composed of a multinucleated giant cells, and then maybe triggered by a systemic bacterial infection. Do you think that it occurs due to the impurities in the filler product, or its physical properties, or it depends on the volume of filler you placed? What are the factors that cause a granuloma to occur? And how can we differentiate between an infectious granuloma and a non-infectious one? Do we do scantigraphy on those things, or we take a swab test? What do you recommend?
I think first and foremost, anything which you deem to be a granuloma can only be confirmed with a histopathological report. So that's the first thing, is that if something is hard and you think, oh, that feels a bit strange, you can't call it a granuloma. You have to call it something like a delayed onset nodule or a late onset nodule, or whatever the terminology is. A granuloma can only be confirmed with a histopathological report. What causes it? Again, it would be nice to know. It could be a combination of the patient and the product. So more particular products stimulate the immune system. Remember, Noury, any filler that we inject in through the skin envelope will evoke an immune response. Now, that response might be just a few macrophages sniffing around and then think, I don't think it's anything foreign. And then, as you say, big multinucleated giant cells around, encapsulated. And then you have your classical granulomas, where they have finger-like projections out, so they're very difficult to excise also. So a granuloma can only be confirmed, and you can get different types. You can get cystic, you can get sclerosing. So cystic are more with HA fillers and collagen, and then you have your sclerosing, which are more with your calcium hydroxyapatite. They look very, very different. They almost look like Tyndall underneath the skin, very blue. The cystic ones sometimes have an infectious component as well. So how do you distinguish between an infectious granuloma and a normal granuloma? Normally with granulomas, they just tend to be hard, firm, discrete lumps. Infectious comes with those classical signs of, or cardinal signs of infection: redness, induration, heat. They look a little bit angry. And again, the treatment's going to be very, very different with those. Remember, some granulomas can spontaneously resolve. So again, that's a very viable treatment option for your patient to say, we can leave this here. You can do ultrasound, you can cut it out, but like I said, they have these finger-like projections. So although it looks small, it spreads out. So again, we have to be very, very careful with these. Again, you can have biofilm in and around these infectious, and again, it's one of the things we see with these semi-permanent fillers. So Artifil, Bioalchemid, all of those. Sculptra, it used to happen a lot when the dilutions were a little bit thicker. Now, I don't know what the dilution is now. They kept changing it all the time. So again,
it tend to occur more with polymers and spheres and such particles. Mm-hmm.
Yeah.
Do you use silicone at the UK? Some people believe that using it in a micro droplet fashion may promote a better, may not lead to a catastrophic effect. Other people think that it lead to edematous granuloma. Do you use it in UK?
What was the product? Sorry.
Silicone, injectable silicone.
No, we don't use any silicone at all. There's been a huge shift from 10 years now. From 10 years on, things like those classic sort of bioalchemids, permanent fillers were used, silicone was used, collagen, which would had a high percentage of immune responses to it. We know we didn't know then. We didn't have the literature, we didn't have the publications, we didn't have the experience then. So now, since then, we've moved away. Certainly, I've moved away. I don't use any biostimulatory fillers at all. I only use HA because it gives me that safety net. So we don't use silicone. So I can't really comment because I've never used it. And again, in the UK, Noury, I haven't seen any complications related to it because I don't think it's being used at all in the UK.
Mm-hmm. Speaking about the treatment of granuloma, do you recommend giving intralesional corticosteroids, fluorouracil, or you prefer to take the oral, the systemic therapy?
Again, it's how you look at it, and if you look at the literature, 5-FU fluorouracil that you mentioned, tends to come up a lot within the literature again. So we need more work on that. Intralesional steroids work really well, but again, it comes with problems. It comes with the fact you can get subdermal atrophy, you can get telangiectasias. So you have to be very wary. So if you're using triamcinolone intralesional, I'd start at 10 milligrams, wait 4 weeks. If it's not gone, go 20 next 4 weeks, 30 the next 4 weeks, 40 the next 4 weeks. So you're really building a little bit of a safety net into that. I also use hyaluronidase because sometimes these granulomas, they're encapsulated. So again, you can break them up a little bit, disrupt them with hyaluronidase first, and then give your intralesional steroids. You know, things like anti-cancer medications, bleomycin have been advocated as well, but allopurinol for gout. There's lots and lots of strange and weird and wonderful treatments, but I've treated 2 very successful in the lower eyelid, 2 granulomas with triamcinolone injections, but they're pretty rare. They're around about 0.2% or something like that. So it's they're very rare. We don't tend to see them that often, and if you do, like you said, you can use intralesional steroids. Again, a little bit of lidocaine will help sort of massage these areas. But always remember, if you're using steroids, to just move up. Don't jump to 40 milligrams straight away.
Mm-hmm. Okay, so to be scientifically accurate, should we say that filler spread or filler migrate, especially when it comes to the techniques of injecting the lip? I guess you are very familiar with the right angle technique and placing the filler at right angle across the vermilion border. And some people, when they withdraw the needle, they give a little point of their injection at the vermilion border. Some people say that this should not be done because it leaves a shelf or a ledge. What is your own opinion about this?
Well, when we use the word migration is the mass movement to a distant area. So I feel, in my opinion, in my head, how migration works, there's only really one place that filler can migrate, and that's from the deep temporal fat to the buccal fat here, because the deep temporal fat's an extension of your buccal fat. So again, that would be pretty much more of a migration. What we have to remember, Noury, is that we've got to get the semantics, we've got to get the words right. I don't like the word spread, and I don't like the word migration. I use a word in the middle. It's redistribution. So it redistributes itself. So we know that the upper lip has 3 compartments. It has a lateral, a central, and a lateral here. And just like any fat compartment, the soothe or any other fat compartment, if you start to fill that up and you start to fill, which is a pretty tight fibrous fatty layer, you could easily fill that up very, very quickly, and the filler has nowhere to go. There's almost little septa which separate the fat compartments, and it just stops and starts to create this shelf. So that's the importance in understanding the anatomy. I don't go outside of the lip here, again, because the needle comes into these lateral and central fat compartments, start to fill them up, and it's outside of the red lip. It's in the white lip, the cutaneous lip, again, where you have these very discrete fat compartments, the perioral fat. You start to fill those up, you start to have a problem. And I think one of the biggest areas you can see this even more is the patients who get this vertical Joker's line appear here. Again, because we have these little false ligaments between the nasolabial fold and the lip called the lip cheek junction, and the filler can't get past, so it holds. You fall asleep like this, and then all of a sudden you have this vertical line, like a vertical Joker's line here. So it's understanding the anatomy, understanding those discrete fat compartments, understanding that the fibrofatty layer in those areas is very thin, and the filler can easily fill it up very, very quickly. So again, you can use a cohesive filler. You can massage it really nicely. One which will integrate. There's lots of different products you can use, but product selection is key, and the amount also. So try to stay inside the red lip, and again, that's the reason why I use a 4mm needle. I don't breach the white lip with the traditional 13mm.
Mhm. I see. Unfortunately, we have reached the end of the upper webinar, and I had a great pleasure. You are such a knowledgeable man, Dr. Lee. But I can't end it without asking you about Lee Walker Facial Aesthetic Academy. What type of activities are you doing right now, especially with this whole COVID crisis? Are you turning some of the courses into virtual, or are still sticking with the hands-on courses? If you could tell us more
Um,
about this.
well, at the moment, I run a mentorship course for 10 months. So it's once a month, and normally the people come to the to my facility to have that. But we're doing it virtually as well at the moment. So we look at every individual area of the face, and we look at the anatomy in depth. So we start with the temple, forehead, periorbital, mid-face, nose, lips, chin, jaw, everything, Botox, complications, male and female face. And we take the delegates on a journey. So we're doing that a little bit now by social distancing. We cut the class in half, and we have half stay at home and half come, so we can keep them apart. So there is a practical element to that as well, and it's all evidence. It's all evidence based. So yeah, it's a combination of both. Like many answers to your questions this evening, Noury, it's normally a combination answer.
Mhm. Thank you so much for your time. I guess you are doing a tremendous and a perfect work at the Facial Aesthetic Academy. Thank you so much, Dr. Lee, for your time and for giving us some of your valuable time to indulge us with your immense knowledge and sharing your experience. It was a great pleasure. I hope when all this whole COVID crisis ends, you may pay us a visit in Egypt. It will be a great pleasure to have you as a speaker in a conference or a
I'd love
course.
to. I was at the Dermal last year in Cairo. It was amazing. So many great people with a. I'd love to come to Egypt to spend some time and share some knowledge with you. And I'd like to extend my gratitude for your invitation this evening, Noury. It's been a blast for me also. So thank you
I
very
can
much.
assure you that the pleasure is all mine, Dr. Lee. Thank you so much.
No,
Our
you too,
audience is
Cameron.
asking me to save this webinar. I will save the webinar, don't worry. Okay, thank you so much, Dr. Lee, and good night. Bye
Oh,
bye.
good night to you too, Noury. Take care.
Bye bye. Bye bye.
Bye bye.